Hello, and welcome to today's webinar, Adolescents, Young Adults, and Opioid Use. When is it a problem and what to do? I'm Tracy McPherson, and I will be your webinar moderator today. I'm a senior research scientist at NORC at the University of Chicago. I provided my contact information here. You are welcome to use it if you have questions about today's webinar or any webinar in this series. You are welcome to contact me. This webinar is produced in partnership with the Adolescent Expert Project, NORC at the University of Chicago, and the BIG Initiative, with funding from the Conrad and Hilton Foundation. I provided the website address as well as our team email. You are welcome to visit those and email us if you have questions about screening and brief intervention for adolescents and young adults, and also to visit our website for more information about our adolescent resources and our training curriculum. Today's webinar is one in a series of webinars this year, and you can see there are a lot of very interesting topics, including a review of screening tools, and these are the most recent validated screening tools that are being used in practice today. You also see that we are expanding our conversation about substance use and screening and brief intervention to examine other risk factors like risk for suicide, other risks associated with other types of substances, including opioid use, which we'll talk about today. And we'll also be sharing with you information about contemporary trends in prevention and treatment, as well as some of the newest literature on risk and protective factors. As you can see, we also are offering workforce development-focused webinars to give you a sense of what some of the evaluations are showing around preparedness and readiness of health professionals. You can download the flyer from our website. Everything is housed on expert.webs.com. You can click on the Webinars tab or add /webinars, and then you can register and you can access all of the on-demand learnings for all of the webinars in our series. All of the materials for today's webinar are found on our website, the expert.webs.com/adolescent-opioid-use. The PowerPoints are already posted, and other materials and resources that may be discussed today are also posted there as well. We will also be putting up an on-demand a webinar. Once our webinars have concluded, we'll be offering this webinar several times in our series, and we hope that you will share that information with others so they can join in as well. We will be emailing you after the webinar, and you'll get instructions on how to watch the on-demand recording, how to obtain your free certificate of attendance, and completing a short evaluation survey. This evaluation survey is really very, very important to us. It's not just your typical training satisfaction survey, but we're really trying to understand about the education that we're providing you, really evaluating what you need, what you want out of our webinar training, and it really helps inform how we might move forward in meeting your needs. You'll be able to ask questions throughout the webinar. You can do so by typing into the questions pane in your GoToWebinar control panel, often found up at the upper right corner. And you can see here it's some guidance on where you can find that questions pane. Some of our staff will actually respond to you as soon as we possibly can following the webinar, and we'll be posting a Q&A from all of the questions that we receive from the webinars on the same website where the on-demand version of this webinar and the PowerPoints are already housed. So you can go back to that site to obtain the Q&A. Now it's my pleasure to introduce our webinar presenter today, Dr. Matthew Felgus. Dr. Felgus is board certified in addiction medicine and psychiatry, president of the Wisconsin Society of Addiction Medicine, and a fellow of the American Society of Addiction Medicine, or ASAM. He has been treating individuals with substance use, abuse, and dependence for over 20 years. Before he went to medical school, Dr. Felgus was a drug counselor and brings that perspective to treating his patients. He has a clinical faculty appointment to the University of Wisconsin Department of Psychiatry and has been lecturing for the past 18 years on addiction issues to doctors and doctors in training, as well as nurses, occupational therapists, physical therapists, and as Dr. Felgus says, whoever else will listen. He has a Bachelor of Science in Psychology from Penn State University, received his medical degree from Hahnemann University in Philadelphia, and completed a psychiatry residency at the University of Connecticut, as well as a research fellowship in substance abuse at the University of Connecticut Health Center. So, Dr. Felgus, welcome. Thank you so much for sharing your expertise with us today. I'm going to turn it over to you.
Thank you very much, Tracy. It is a pleasure to be here. I'd like to thank everyone for tuning in to attend these. So we are just going to jump right in to opioid use in adolescence. Now, I do not seem to have control of the slides right now. So there we go. Thank you. Adolescents, young adults, and opioid use. When is it a problem and what to do? So what I want to just do right off the bat, I want to keep people as engaged as possible. Normally when I speak, I do take questions throughout my talk. That will not be able to happen today, but I am very happy to answer questions. Again, if you send those in, there will be, I will do everything I can to get you an answer. So if we can forward this slide again to the next one. I do have a poll question that I would like all of you to answer. So which of the following are warning signs that a young person could become addicted to their opioid medication, prescribed or not? But we're starting here. So I would like you to answer. There may be more than one right answer, but I would like all the participants to answer, to choose from one of or more than one of these four options. And so I will give you all a minute or so to answer these, and then we'll be talking. We'll be talking about these. I'll be incorporating these into my presentation. Okay, so you guys are a pretty educated group. Honestly, the answer is all of the above. So yes, it sounds like just about everybody's realizing that current life stressors are warning signs, but actually all of these are, and this is exactly what I am going to be talking about over the course of the hour. So we will now move. So this is part two of the poll. Same question, actually. Which of the following are warning signs that a young person could become addicted to their opioid medication, prescribed or not? So here is a choice of four more. There may be more than one correct answer. So I'll give everybody a minute to make their selections on this part of the question. Okay, so most of you said all of the above, and actually the first Three answers: history of past trauma, yes, a warning sign. Other substance dependence, yes. Prescription for a benzodiazepine, a little less, and I would not be surprised. A lot of people are on benzodiazepines. That in itself does not increase risk, but again, this is exactly what we're going to talk about. And this last one, cannabis use 2 to 3 times a week, that actually is not one of the high risk factors. But again, this is not about playing gotcha. This is about, starting the dialogue and enhancing the understanding about adolescence and opioid use. So it does look like, I don't know if there is a way for me to be able to get control. I have no control of the slides right now. So there we go. Thank you. Now I do. Perfect. So I'm going to talk about these questions a little more. So what I'm doing, I'm dividing this talk into, I'm assuming that you're, clinicians in some form. So whether you're counselors, doctors, folks working in the school system, folks working in the legal system, I'm breaking this up when I talk about clients, that's any of the above. But I'm dividing it up into, when a young person, before they get exposed to an opioid, once they start it, and then the progression. How do you know if there's a developing problem? So before exposure, in general, past overuse of central nervous system depressants. So that includes the main ones that are out there: alcohol and benzodiazepines. So those two, along with opioids, are the primary central nervous system depressants that people are utilizing, both by prescription, socially, and of abuse. So any of these, there's definitely crossover. Use of any one of these does increase the use of opioid overuse. There's likely a greater risk with alcohol or benzodiazepines than there is with overuse of other substances, such as cocaine or cannabis. But both the doctor and the patient must maintain that awareness. So that part of the question where I said cannabis use 2 to 3 times a week, that is below the threshold of somebody being cannabis dependent for most people. But again, it's something, none of these rules out. This is always something you want to be aware of. I'm going to speak more about this second point. We don't talk too much about this, but anybody that's worked clinically with individuals using opioids, whether they're young people or not young people, both themselves or history of family members becoming energized from opioid medications does very much increase the risk. And I will speak, this is a very important point, and I'll speak a little more on this. High anxiety or life stressors also both increase the risk of developing a problem during somebody's early exposure to opioids. And greater than 7 standard drinks. Now, the reason I have capitalized standard is one person's drink may not be another person's drink. So 12 ounces of beer, 5 ounces of wine, 1.5 ounces of liquor is all a standard drink. So if somebody is drinking a 16-ounce glass of alcohol nightly, but they're pouring about half of it with alcohol and the other half with juice or soda, that's not one drink. They may think of it as, oh, well, I'm only having one drink, but that's probably more like 3 to 4 standard drinks. So greater than 7 standard drinks per week does raise the risk of developing a problem with opioids. Okay, so can you forward this slide? Thank you. High risk factors does not mean that somebody is intending to abuse their opioid medication. Sometimes it is necessary to utilize the medication, and this should be done as safely as possible. If somebody is having surgery or wisdom teeth extraction or is in an accident, sometimes it is unavoidable to utilize an opioid. and just all of the experimentation that's going out. Teenage years are unfortunately a time for experimentation with all kinds of things, and that does include substances. And we have not developed a reliable tool long term to keep teenagers from experimenting with substances. So, the Just Say No campaign unfortunately did not work. But this is important to keep in mind. Nobody starts using anything planning to develop an addiction, and especially with teens, none of them believe that it's ever going to happen to them, even if they do have affected family members. However, educating somebody that they are at higher risk in a non-judgmental way can make a major difference, and I will talk about that more. And as I mentioned, adolescents, young adults, a lot of people, they tend to feel invincible, need to experience things on their own. They don't like to listen to other people's advice. They want to figure out everything on themselves. So next slide, please. Thank you. Energized by opiates. So the majority of people, when they take an opioid, will become tired, nauseous, cloudy, maybe all of the above. However, some people, and anybody who has worked in this field, I have not come across one person, whether drug counselor, doc, school counselor, that has not met people that are using and abusing opioids where they say, these give me energy. This is a specific type of brain wiring. It does tend to run in families, so it is a genetic variation. I have no question that we will be able to localize this in the not too distant future, exactly what the genetic variation is. I do not know what it is right now, but this is genetic. It has nothing to do with how much willpower somebody has. It's just some people will respond differently to opioids based on this variation. This will occur at first exposure. So if you give a kid, I had a patient who was in treatment for opioid dependence, who had a young child who had a tonsillectomy, the child was given pain medication after the tonsillectomy, and the child's personality totally changed. This was a very reserved, quiet kid, became very loud, boisterous, told his mother that he wanted to jump up on the table and dance, which he's never done anything like that before. Mom was understandably freaked out, but this was actually a very good example of this energizing effect that just happened. This child was not abusing substances. Education to this risk factor really is key to preventing addiction, because if you can let people know that this can happen before they get exposed or before they start abusing a substance, they will have a higher level of consciousness. Next slide, please. Positive reinforcement. So the folks that have no idea and they take an opioid and they feel energized and they feel great, if it makes you feel good, you're going to do it again and again. And this is just human nature. This is a major risk factor for addiction to opioids. If somebody was to do a survey on people that currently or even in the past have had an opioid dependence and did a survey on whether or not they found opioids energizing, the percentage would be very, very high. This is the population, and this is a pretty common genetic variation. This is the population that is becoming, having problematic opioid use. Patients will often say, I hear this all the time in my practice, they had no idea this could happen to them. They were otherwise upstanding citizens. They were never intending to abuse anything. They just felt better than they ever had in their life, and it just got out of control. Next slide, please. So this is a less than 3-minute Doctors, counselors, everybody's busy. I've heard this from physicians a lot. Well, I don't have time to do any kind of screening like this. So I am providing, and feel free to paraphrase, this is a much shorter than 3-minute conversation for all patients prior to being given their first opioid prescription. If you feel energized after taking this medication, you need to call the office and let us know. This shows you may have the brain wiring to develop an addiction to this type of medication. It is based on genetics. It is not anything you are doing wrong. It is not about willpower or good character. It can happen to anybody with this type of brain wiring, and most people do not know they have it until they take this prescription. However, this means you need to be very cautious with any opioids. Never take extra, and if you can, have somebody else hold it for you. Now, ideally, this would be something that a physician or a nurse would do, but this is also something that, as a counselor, whether it's a mental health counselor or as a school counselor, if you know somebody is having some kind of a surgery where they're going to get an opioid prescription, if somebody's, even if they're not high risk, this is a very good conversation to have with people. And if you notice, there's nothing judgmental about this. There's nothing saying, I think you're going to get addicted, or that I don't think you can handle this medication. And this is important because we do need to keep people open. As soon as somebody starts feeling like they're being judged or accused, they're not going to be as open as to listening. Next slide, please. The basics as far as opioids. And this happens, I hear this all the time with my young adult, teenage, college student patients. Despite, believe it or not, it's hard to believe with everything in the news about the opioid epidemic, there are still young people who are thinking, well, doctors give them out. My grandmother takes them. She seems okay. So even if they're being acquired on the street or you're taking it out of somebody's medicine cabinet, there really is still this belief, and this is how people are still getting drawn into the opioid epidemic, that these pills are safe because doctors are prescribing them. And that is very powerful despite everything that we're hearing in the news. So it is something we need to be aware of. Next slide, please. They're central nervous system depressants. The effects of opioids are similar to the effects of alcohol. There's a lot of people that get cross addicted, so they drink and then they discover opioids and they're able to stop drinking, and then they go off of opioids and then they start drinking again. There really is a lot of cross effect with these two. The greatest risk with opioid use is of respiratory depression. And this is why it is common for people to get, even teenagers, to get prescriptions for one of the PAMs, lorazepam, clonazepam, alprazolam. Benzodiazepines are very commonly used to treat anxiety. Mixing an opioid, whether it's, hydrocodone or something on the street like heroin, mixing those two increases the respiratory depression. These medications both cause respiratory depression, and it's a situation where 1 + 1 = 5. So an opioid plus a benzodiazepine equals recipe for an overdose. I am never failed to be surprised how many physicians are not aware of this effect and will prescribe both of these medications, or they will know that a patient is on one of these, let's say something like lorazepam, and they do not caution them if they're on pain medication. And this is where a lot, I would say probably the majority of the overdoses are taking effect, is the mix of these two categories. Next slide, please. So I talk about this a lot. My background is in drug counseling and mental health, and I really do focus on the mental health drivers of addiction. In the 25 years that I have been practicing, I have, and I can say never, I have never come across any individual that I have evaluated that did not have one of these 4 things driving their addiction. Now, sometimes the patient will say, nope, I don't have any of that, never had depression, no anxiety, no trauma, and I sleep very well, thank you very much. Digging a little deeper, I always say it all comes out in the wash. But depression, anxiety, trauma, and insomnia are critical to keep in mind when you are looking at somebody that, even before they get involved in substances, that is vulnerable to becoming abusing and becoming addicted to it. And then also, once they're using, having to treat one of those four before they can actually even feel comfortable enough to stop using. So next slide, please. Opioid use. So I'm going to talk a little bit about the interface between major depression and opioids. It is a major clinical, situation that we see. And it's kind of like which came first, the chicken or the egg, because opioid use may cause major depression. Remember, opioids are central nervous system depressants. Depression, however, is a risk factor for the abuse of opioids. And then when you flip it around again, opioid use does create a challenge in medicating depression because you're taking a depressant. And as I tell my patients, what happens when you combine a depressant and an antidepressant, it doesn't make it impossible to treat the depression, but it definitely makes it challenging. Next slide, please. Depressed opioid users often cannot maintain their sobriety if their depression is not treated. And this is important to keep in mind because in substance abuse treatment, we want the person to stop using. However, if somebody has an underlying depression and the opioid is numbing out that depression, they are going to actually feel much worse. Coming off of an opioid does not feel good anyway, but even past the withdrawal phase of things, if somebody has an underlying depression and the opioid has been numbing that out, if they go off of that opioid, they are going to feel their depression more. So they're going to feel a lot worse, and that is going to be much more of a trigger to use. And as I mentioned before, however, opioids can depress the medications for depression. Those antidepressants will still work, but they're having to work a lot harder, and the prescribers need to be aware of that. Next slide, please. So, as I mentioned before, almost always underlying the substance use is that big four: depression, anxiety, trauma, and sleep. Next slide, please. So, a lot of people get caught up in the idea, well, we need to know which came first. Is it major depression, or is this depressed mood that the client is complaining of just because of their opioid use? Or is this a major depression, or is this a substance-induced depression? Next slide. So I want to say some things that are somewhat unique to teenagers and depression. Depression can occur at any age, but some of the things that are unique with younger people, not that adults cannot be poor historians and often out of touch with their feelings, but that's probably more true just from the developmental phase of where adolescents are. They're not often able to tell you how they're feeling, or they just don't want to tell you how they're feeling. They can often be in treatment under duress. Either they're being forced by families or schools or the legal system if they've gotten in trouble. So their trust is not super high. So they may not disclose how they're feeling. And then probably one of the biggest issues that happens with adolescents and depression. Now, anybody that treats kids knows that depression in children looks more like behavioral problems than it does that, melancholy stereotype that people think of when they think about depression. With adults, it looks more like that melancholy presentation, and teenagers are a mix. So for some teenagers, these behavioral problems are the primary manifestation that there's a major depression going on. Now, if you sit them down, if you give them one of the really good depression screens like the HAM-D, it will come out, but you may not go to that right away because you're thinking this is more just a behavior problem. This teenager does not look depressed, but you always do want to ask and do a screen with an adolescent that's having behavior problems. Next slide, please. So why does this happen? And I share this slide and I give this explanation to my patients a lot, because a lot of people do feel like if they just tried a little harder, whether it's stopping substance use or dealing with a major depression or anxiety, if they just tried a little harder, they could do it, and it's just because they're not trying hard enough. There's two ingredients why somebody develops pretty much just about anything in mental health, whether it's depression, anxiety, substance use. The first ingredient is a genetic vulnerability to that condition, and obviously that's not something that anybody can control. I'll tell my young patients, well, you can blame your parents, but they can blame their parents. It's genetic. The second thing you need is enough stressors. And what I tell people, if even with the genetic vulnerability, if you were going somewhere to live in a stress-free tropical paradise, you may not ever develop the condition. However, life stressors matter, and this is where counseling for substance abuse treatment, it is never just a question of taking a medication, because the medication does not help people deal with their stressors better than they are. And honestly, we all can use that to deal with stressors better than we do. But when somebody's got the genetic vulnerability for another condition, it really becomes that much more important. So I do share this idea a lot with my patients because they do need to understand, number one, this is not, there is a vulnerability. It's not their fault. Number two, however, that doesn't give you a total free pass. Well, it's my genetics, I can't do anything about it. They do need to be working on better coping tools for their stressors. Next slide, please. So, to treat or not to treat mental health symptoms, I have heard physicians, otherwise educated, say that a patient comes in, I've heard psychiatrists say this, a patient comes in with depression and they're using opioids. Well, the doctor says, well, you know what, I can't even treat their depression until they've been substance free anywhere from 3 to 6 months. And actually, when I was trained as a drug counselor back in the late 80s, I was taught this, not non-medical. I learned better once I went into medical school and did psychiatry training, but this is what I was taught as a drug counselor. People still believe this. This is not true. But there's two issues with medication. There are some people that are very invested in 12-step programs that feel like in order to work their program, they should not be on any medications to treat some of these biological conditions. So for some people, they're refusing medications that they probably need. But on the flip side of that, there's other people, and anybody that's dealt with individuals that have abused substances understand the idea of there are people that'll just say, doc, give me a pill, any pill, I don't care. Basically a magic bullet, that they're just so focused on getting a pill to fix something. And honestly, that's not just people that abuse substances. We live in a culture that just wants that pill as a quick fix, and that's not realistic either. So this is part of what we're factoring in when we decide whether or not to treat. Next slide, please. A couple things I want to say about substance-induced disorders, because sometimes it is substance-induced. Sometimes the substance did cause an underlying depression. They do last past acute withdrawal. Obviously, they can look very different in individuals, and they are noted, it's noted by improvement with cessation of use, but not always a sufficient improvement. There are people that have the genetic vulnerability to depression. The substance may have triggered this episode, but once you push them over that cliff of depression, even when they stop using, the depression does not bounce back in a very short amount of time. Next slide, please. There is, and this is important to keep in mind with treating, there is a higher risk of suicide and self-injury in individuals with substance-induced depression versus a major depression. There's a higher likelihood of panic attacks, which people really feel like they're dying with a panic attack, with substance-induced anxiety versus a generalized anxiety disorder. Therefore, when in doubt, treat with non-addictive medications. What is very nice about the medications that we have for depression right now is they're basically impossible to overdose on. And even though the labels, I don't understand why pharmacies do this, they'll say, do not drink if you are taking this prescription for Prozac or Paxil or Zoloft. The reality is, no, it's ideally they shouldn't, but it's not dangerous. I have had people that have relapsed that were on an antidepressant say they've relapsed on a substance and they stop their antidepressant because they think it's dangerous. That actually compounds their risk of worsening their depression. So hopefully, hopefully I've made my point with that, that even you don't have to spend all the energy worrying about which came first. Is it substance induced? If there is a question, if they are not bouncing back within 2 to 3 weeks after they get off of the substance, if they're still complaining of depression symptoms, I would treat. And there are some references at the bottom of this slide. So next slide, please. So is there a problem? So next slide, please. So your adolescent client has been experimenting with opioids. She is insisting that there is no problem. Which of the following are risk factors of a developing dependence for this, for somebody in this population? Okay, so now this is interesting because less of you felt like any of these were risk factors than at the very beginning. So that is a little interesting. All of these are possible risk factors, and that slide shifted a little quick, but the patient in question, this was an adolescent who was not using every day. She was, insisting she was not addicted and could stop if she wished. So can we go back to the results of the poll question? Okay, so what I wanted to say, so all of these are potential risk factors for a developing dependence. Now, only about 2/3 of you felt that the prescription for the benzodiazepine. Part of the risk with that is not so much, obviously, there's a medical risk if somebody's messing around with opioids and on a benzodiazepine, and hopefully you would all be able to know enough to educate this client, hey, this is really dangerous. But the other thing that happens, mixing an opioid and a benzodiazepine, and my patients tell me this all the time, it creates more of a euphoric feeling than either of these medications alone. So even if somebody gets energized from their opioids, they are still at more risk. Mixing a benzodiazepine, it makes that good feeling that much better. So let's go back to the slides because there's another group of questions for this. So number 4, same client experimenting with opioids, insisting she's not addicted. Again, which of these following are risk factors for a developing dependence? Okay, it is interesting. So most of you, actually a majority of you, felt these are all risk factors, but the answer is it depends. So there, if I was grading this, I would say that this would be one of those test questions that some like one of those not test questions, but one of those like experimental questions that sometimes get thrown in, because this is going to introduce the next topic that I want to talk about, and then we're going to look at this again. So let's go to the next slide. So I want to introduce a substance use continuum. Now, this is not something you're going to be able to open up a textbook and find, but this, in my experience, this is one of the tools that I developed actually back when I was a drug counselor. The reference to the paper that it's published in is at the bottom of this, but this, and you guys get to decide if this is useful, do with it as you wish, but this is a progression. Anyone who uses any substance goes through these levels, and I have found it very powerful and useful with my young clients to go through this. Not only are they accurately able to put themselves in the right zone, but they don't feel judged, and it really creates a model for dialogue. So I'm going to jump into this. So there's 5 zones. Just keep this mental picture. It is applicable for any substance. The paper is relevant. It's about alcohol and adolescence, but it is equally applicable to opioids or any other substance. So let's, can we go forward? So there's no skip points, and it is possible to move backwards up to a point. We all know about the point of no return with addiction, and I will talk about that. So let's go to the next slide. So zone A is non-pattern use. And whenever I talk about this, people kind of apply it to themselves. Anybody out there who, drinks even occasionally is somewhere on the continuum for alcohol, but it does also apply for opioids. Everyone starts here. There is no identifiable pattern in the use. Somebody may become drunk or high and still be in zone A. People in zone A tend to focus on the consequences of their use. So they're like, okay, wait, I have somewhere I have to be tomorrow. I'm leaving at 10 o'clock tonight. And they take off, and there aren't any consequences from their use. So let's move on. Sometimes zone A is best defined by zone B. Taken together, zones A and B, and this, most people could think of this more easily with alcohol. This is what people think of when they think about non-problem use or social drinkers. But we're all creatures of habit. Most people that don't have a problem with a substance actually are in zone B. This is somebody who uses in a predictable, consistent manner, whatever their substance is. So every Friday night or after work, get-togethers with certain friends, even if that doesn't happen on a regular basis. After an argument with a significant other, they may run out and get high or pour themselves a glass of wine. One situation with a pattern defines this zone, and there are still no resulting negative life consequences. So this, again, A and B are what you could think of as, non-problem, early use, social drinker, whatever the term you want to use. This is that group. And we don't talk about patterns enough. Patterns are very much the jumping off point for further use. So let's go to the next slide, zone C. Any unintended, this is negative consequence use. So somebody's use of substances, including the after effects, has caused them either from doing something they planned to do or impacted, it's kept them from doing something that they, wanted to do. So they're either avoiding it or they're just not participating, and avoiding is the same, but it's any unintended life consequence resulting from substance use. This is the earliest sign that there is a problem, but this individual is able to control it. So that adolescent client that I, told you about in the poll question, who is insisting she can stop at will, if she's in zone C, she can. However, zone C is an unstable zone. When somebody has a negative consequence, they're going to do one of two things. They're either going to pull back and go, whoa, I'm never going to let that happen again, or they're going to go, whatever, and they're going to keep moving forward. So people tend to move one way or the other from zone C. They don't tend to stay in zone C for a very long time. However, zone C can meet the DSM-5 criteria for substance use disorder severe. So it's a very heterogeneous population in that substance use disorder severe. So next slide, we'll talk about D. And normally, like I said, I've given 2-hour talks on just my substance use continuum. I wanted to introduce this to you. If people find it interesting or there's some things they have questions about, please ask. Zone D is psychological dependence. So this is a pattern of negative consequence use. Use of the substance is taking the place of other activities, or they may be unable to be in certain situations if they don't have their substance. Binges are characteristic. However, there is a lack of physical addiction. So the college student that is using whatever substance all weekend, they get it together, they go to classes during the week, they're not in withdrawal. This is zone D. Next slide, please. Zone E, this one makes sense. This is the physical addiction and psychological dependence. Withdrawal on being without. Use is no longer a means but an end. They're not getting high. They're feeling normal. And not all substances have a zone E. The hallucinogens, there's no evidence for a zone E with hallucinogens. There's not a physical dependence, but A through D equally apply. So next slide, please. So this is what the substance use continuum looks like. There is a point of no return. We've all seen that, where somebody's use gets to the point where they cannot pull back. Again, that's a much more involved talk. The line is about a quarter of the way within zone D. So anybody whose use has crossed that line, they really have a dependence, they cannot use recreationally. That's their continuum. They're either in zone D, zone E, or on the aisle of abstinence. And like I said, this is a talk in itself, but I wanted to introduce you to this because this is a highly effective tool with teenagers. And like I said, I've seen they can put themselves, you describe this, they can put themselves in the right zone. Let's go to the next slide. So now what I'm doing, this is the poll question again. And again, the majority of you, this is that last one, the majority of you thought that all of these were a problem. And the answer is yes, all of these are risk factors. What I did is not so much parents going through a divorce, that's just a risk factor. Difficulties in school since starting use, that is a pattern. You can't, if it was just one-time negative use, that wouldn't be causing difficulties in school. So that's a pattern of negative consequences. That's zone D. Engaging in risky behavior while using, that would be zone C. That is a negative consequence. Now, if that is happening repeatedly, then that becomes zone D. But just engaging in risky behavior, if it's a one-time or a two-time, I give people a little credit for a learning curve, that's zone C, and you kind of don't know which way they're going to go. Using every weekend, that is zone B unless you know that they're having negative consequences. So I just wanted to use those questions to illustrate, you know, how the continuum can be applied. Next slide, please. So things can change. So somebody may not have a problem at one point and then things advance. So opioid use that is advancing obviously can cause an increase in mental health symptoms, inability to work, lack of social supports, and then somebody starts relying on the opioid for coping with any of the above. Next slide, please. So, warning signs. I'm trying to cut down on my use, but I'm going into withdrawal. Next slide. So I want to say a little bit about opioids and anxiety. Extremely, probably the most common of those big four. This is the most common situation I see, is that mix of opioids and underlying high anxiety. There is a high degree of overlap between withdrawal and anxiety symptoms. While anxiety is not responsible for the opioid epidemic, it is a major barrier for individuals to stop using. And I will demonstrate this in a couple of slides. So next slide. Opioids numb emotional pain, and individuals with any mental health issue, anxiety, depression, trauma, they do want to numb out. Self-medication is a pathway to addiction, and there are people that will say, I'm not trying to get high, I'm just trying to lower my anxiety or feel normal or not be so down. So there are people that are addicted that it's not even about getting high, it's about self-medicating. Next slide, please. Anxiety can present as all kinds of things: general unease, panic attacks, social withdrawal, phobias, obsessions, compulsions, and it's common for anybody we are a quick fix society. So rather than get evaluated and do cognitive behavioral therapy or any of the other good techniques, people just want to take something. If it's not prescribed, they want to treat their anxiety because it doesn't really treat it with opioids, alcohol, cannabis. Cannabis does not treat anxiety, but it does cover it over, or any other substance. Next slide. So I want to show you something, and there's a reason I put it in this little, I'm kind of made a little schematic out of it. These are just symptoms of anxiety out of a general mental health textbook. So remember these, blood pressure, heart rate up, heart attack, chest pain, feeling like they're smothering, choking, out of body, feeling numb, depersonalized, having sweating, chills, hot flashes, restlessness, GI cramps, diarrhea, shaking, tremor, inability to concentrate, dizzy, lightheaded, tingling, fear of losing control, going crazy, dying. This is not anything having to do with addiction. This is out of a mental health textbook. However, I'm going to show you. Next slide, please. This is out of an addiction textbook. These are the symptoms of opioid withdrawal. So try to keep that mental picture of what I just showed you with anxiety. These are opioid withdrawal. They're not talking about mental health. Increased blood pressure, heart rate, sweating, chills, hot flashes, restlessness, dilated pupils, muscle aches, GI cramps, diarrhea, nausea, vomiting, fear of dying, tremor, yawning, goose flesh, runny nose, watery eyes, and bone pain. Next slide. So how do you even know? And what's going to happen? Individuals that are opioid dependent, they are highly sensitive to physical sensations in their body. And most of those folks, especially in the early stages, their mindset, everything is withdrawal. And that is very reinforcing to continue to use. So how do you even sort it out? Anxiety is a huge part of opioid withdrawal. You want to try to take as good a history as possible of past anxiety symptoms, even when they're not using. Corroborate with family and friends. I've had people that say, nope, I'm not anxious at all. And if I have a family member with them, the family member's like nodding vigorously, yes, you are. So it is important to get collaborative information. What are things like when they're abstinent, or before they started using, and looking for physical evidence. The goose flesh, the runny eyes and nose, that is a withdrawal symptom. That's not an anxiety symptom. So looking for some of those physical symptoms really can help you try to sort out which it is. But the reality is it can be both, because being an opiate withdrawal, who wouldn't have anxiety? Next slide, please. Your client may be addicted to opioids. Now what? Next slide. Encourage honest, open dialogue. Finding out how much they're taking. Just because somebody has a prescription, that doesn't mean that they're not taking double or even triple that. You want to find out. Do not, and I've had this happen, well-meaning counselors, do not encourage a physician to cut off their prescription at the first sign of a problem, because the patient is often going to turn to the street for more pills or heroin. Next slide. Screening for the big four. There are many available screens, and we can talk more about that at any of the basic mental health screens. Next slide, please. Refer to pain treatment if needed, and I am a huge fan of the alternative therapies. There's a lot of them out there: massage, acupuncture, chiropractor, neuromuscular. Refer to specialized counseling, so either drug counseling or mental health counseling. Good boundaries in a pain contract. Keep in mind, the majority of physician prescribers do not have addiction training. So if you're a counselor, you may need to be the one to give them, hey doc, this is how we can help this patient. No early refills under any circumstance, and slowly lowering dose while you're getting them into more specialized treatment. Next slide, please. So I'm going to say a few things about opioid replacement therapy, the good and the bad. There are three common, what people think of as Suboxone, Buprenorphine, Naloxone, Naltrexone, which people know the injectable Vivitrol, also oral, and Methadone. So next slide. Why do it? And I always, I do prescribe Suboxone and Vivitrol in my practice. And there's whys and why nots for both. It is effective, proven treatment. It keeps clients in treatment, so it's the carrot. It's a blocking agent for other opioids. It is less likely to be abused, but not impossible. Next slide. if used properly, and doctors do different things. Some doctors will just put people on a fairly high dose and keep people on it for, indefinitely. And there's positives and negatives. I do not prescribe that way, but I think that would be that would be a separate 1 hour lecture. I think it is important with a younger population that, the idea that this is lifelong treatment does not sit well with a lot of people. So it's one component of a well-rounded treatment program. Just Suboxone alone is not good treatment. They need to be doing the counseling, ideally mental health and addiction. It is safer in overdose. So those are the pros. Next slide. Now, some of the, what are the drawbacks? Over-reliance on medication versus recovery tools. And again, that's human nature. The opioid replacement may be started at a higher relative dose. So if somebody's taking 40 milligrams of oxycodone a day, that's about 4 milligrams of Suboxone, and some less experienced prescribers may give everybody 16 milligrams. They're on 4 times what they were on before. So you kind of want to try to keep it at a relative dose, but it doesn't always happen. It is possible to abuse opioid replacement medication, and the belief among some prescribers that this is lifelong treatment. Next slide, please. Yes, you can get high if you are not opioid dependent. So the Suboxone does get diverted. It's a party drug for those without an opioid habit. It's prevention of withdrawal in those using that are not interested in treatment. And it's self-detox for those trying to quit. Most of the time it doesn't work because people don't know how to appropriately detox themselves. So more often than not, they wind up relapsing. Next slide. Injectable naltrexone, people think of that as Vivitrol. It blocks the effects of opioids. I should say 21 to 28 days. Some people it wears off sooner. More programs, residential and incarceration, are offering this option at discharge. This is a good thing because it prevents overdoses. The most high-risk time for somebody to overdose is when they just get out of residential or jail, prison, because their tolerance is low and they use what they're used to using. So this Vivitrol really saves lives. It is a good option for motivated individuals. Next slide, please. It's not an opioid, so these are the pros. It cannot be abused. It's got no street value, and it does save lives. I'd mentioned that. So next slide, please. Why not? It is expensive. Not all insurances cover it, but more of them are. It's not an opioid. And if you remember, I said people that have these underlying mental health conditions, they do want to numb out. And Vivitrol, injectable naltrexone, does not numb them out. So I've seen people have a harder time with their anxiety or their depression on Vivitrol. That doesn't mean that it's not a good option, but you do have to do more intensive mental health treatment. Maybe done under duress. That's never a good thing if they're kind of forced as a condition to be released from jail. Not just young users, but opioid users may try to overcome the block as the injection wears off, and then they can overdose. And pain medication may not be as effective. So people need to carry a wallet card or a bracelet. If somebody is in a car accident and they're on Vivitrol and they get rushed into surgery and they're unconscious, the anesthetic and the pain medication is not going to work very well. There are ways to overcome this block, but the treaters need to know that somebody's on this. Next slide, please. Methadone's been in use for a long time, since the 1960s, must be given in a clinic. It blocks other opioids, it reduces cravings. It can be overdosed, so it is more lethal than Suboxone. People can nod out at high doses, so they do look like they're stoned, and in fact they are stoned. And ideally, counseling should be provided along with the medication. Next slide, please. So in summary, addiction is a disorder of brain wiring. Medication, and I do have a resource down here, and this is something that actually just came out in the Journal of the AMA, American Medical Society, the pediatric version. Medication for opioid use disorder in adolescents is more effective than behavioral treatment alone. However, it is not a substitute for treatment. We cannot make anybody ready for treatment. All we can do is provide the information, and that really is what I've spent my career doing. We can offer compassion along with good boundaries. So thank you next slide. I believe that is the last slide. So thank you very much.
Well, thank you, Dr. Felgus. Certainly, you really grabbed my attention. A lot of information that I had not heard before, and I'm looking forward to having you back to dig into some of these topics even further. So thank you very much. I think this is going to be quite the enduring resource. Even beyond our webinars, I think there are many both practicing and both in education settings that can use a lot of this really good information. So thank you so much. In our last few minutes, I just want to thank everyone who attended today with us and hearing Dr. Felgus. I hope that everyone enjoyed it and got as much out of it as I did. If you are interested in those PowerPoints, they are at the expert.webs.com website on the webinar page specifically for this webinar. And as a reminder, you are going to receive a follow-up email from us with instructions on how you can watch the on-demand recording and how you can obtain a free certificate of attendance. And we will be including a link to a very brief evaluation survey that we thank you very much for participating in. We would also like to follow up with you in the coming months as well, and we hope that you will come back and join other webinars and that you will stay with us throughout this series. And last but not least, I provided contact information directly to me and to our expert team. If you have questions about expert implementation, evaluation, or training with adolescents and young adults, and you're looking for some telephonic technical assistance, you're welcome to contact us. And finally, I thank everyone for attending, and Dr. Felgus, let me thank you again. And I want to say thank you to everyone and for being on today's webinar, and I wish everyone a great day.